Good evening, and thank you, Dr. Vikas and team, for inviting me to speak on this rather important topic of supportive care in cancer. The topic for today is innovative treatment for chemotherapy-induced nausea and vomiting. It is important because it is one of the most common problems associated with chemotherapeutic agents. Nausea is more common than vomiting. 60% of patients have reported nausea alone. And unfortunately, there is no definitive treatment for nausea. We keep using antiemetics for nausea, which may or may not work always. And severe nausea and vomiting do affect nutrition and subsequently the patient's quality of life. Now, though the topic mentions that innovative treatment, actually the number of drugs available is limited, and we have these drugs since a very long time. So the innovation rather comes in using these drugs wisely than just adding one drug after the other. Just to mention the categories of chemotherapy-induced nausea and vomiting, the acute nausea or vomiting happens within 24 hours of chemotherapy, which is seen in about 30 to 90% of patients. Delayed emesis is seen at least 24 hours post-chemotherapy. It usually peaks between the second and the third day, and 30 to 60% of patients get this delayed nausea or vomiting. Breakthrough nausea or vomiting happens within 5 days post chemotherapy, despite optimal antiemetic regimen used, and these often require some rescue therapy. Refractory nausea or vomiting happens in a very small number of patients thanks to the excellent medication available today. But we do get some of these patients where, despite maximum antiemetic protocol used, these people keep on vomiting. And anticipatory nausea and vomiting, which is triggered by sensory stimuli associated with even chemotherapy administration, it could be as simple as the smell of the chemotherapy drug, or even the site of the hospital or site of the chemotherapy drug. And it is not uncommon. It is seen in 10 to 45% of patients. There are some patient-related factors which are important. If a patient has had prior bad experience with chemotherapy, these people have increased risk of CINV. Women, by natural selection, have a worse time with CINV compared to men. Younger people are more susceptible to CINV than older patients. Surprisingly, people with a significant history of alcohol consumption are less susceptible to chemo-induced nausea or vomiting. And patients who rapidly metabolize 5-HT3 receptor antagonists are obviously going to be more susceptible to severe CINV, and certain polymorphisms in the 5-HT3 receptor can also increase the risk of CINV. Patients who have experienced acute emesis with chemotherapy are significantly more likely to have delayed emesis, and anticipatory emesis is probably going to happen in these patients who had a poorer control of their chemo-induced nausea and vomiting in the previous cycles. There is a small study which shows that history of motion sickness may predispose to anticipatory emesis. There was an interesting study at the ASCO 2022, this rather small study, about 191 patients enrolled. This study presented a predictive score which showed the promising predictive power, and it is going to be validated in further phase of the study. There were 6 important predictive factors found. One was emetogenic potential of the therapy, educational status of the patient, nausea and vomiting due to other medications, motion sickness, which was found out by history, anxiety from therapy in general, and anxiety from nausea due to chemotherapy in particular. These were important 6 factors, and we all agree that I'm sure we all see these things in practice also, that if a patient is anxious or the patient has had bad experience with chemotherapy earlier, he or she is likely to vomit more. I strongly believe that even we need such a score for Indian patients, because our dietary habits, our dietary preferences are rather different compared to those patients in the West. Emetogenic risk and emetogenic drugs. Now, this is something which has been oft repeated, but it is worth mentioning here that type of chemotherapy regime administered is the most dependable risk factor for chemo-induced nausea and vomiting. All these chemotherapy drugs vary with respect to their ability to cause nausea and vomiting, and that is what we call the emetogenic risk. And not only the drug, but the type of the drug, its dose, route, and schedule, as well as the combination of the drug with other chemotherapeutic agents can affect the emetogenic risk. We have seen that doxorubicin given rapidly can cause more vomiting than doxorubicin given over a prolonged infusion. Now, why is this emetogenic risk and emetogenic drug risk important? We've seen this table so often. Highly emetogenic combinations like anthracycline with cyclophosphamide, one of the commonest used combination in breast cancer, cisplatin, dacarbazine, or even single agent doxorubicin more than 60 milligram per meter square is known to produce nausea and vomiting. Whereas the moderately emetogenic drugs are drugs like bendamustine, carboplatin, cyclophosphamide less than 1500 milligram per meter square as a single agent, or cytarabine more than 200 milligram per meter square. Lower doses of doxorubicin and epirubicin are also moderately emetogenic, and so is ifosfamide, irinotecan, and oxaliplatin. Other drugs like taxanes, 5-fluorouracil, etoposide, gemcitabine, eribulin, and our monoclonal antibodies. These drugs are only low emetogenic, have a very low emetogenic potential, and the risk of vomiting is probably closer to 10% than 30%. Now, why is this important? Because most of the oncologists tend to underplay the emetogenic potential. This is an interesting study, a European study. This was to determine the European oncologists' practice patterns in chemo-induced nausea and vomiting management and identification of the risk factors which contributed to antiemetic treatment failure. Now, the survey showed that the emetogenic potential of chemotherapy was underestimated. 1/3 of the oncologists perceived that anthracycline cyclophosphamide combination, which is actually a highly emetogenic combination, they thought it to be only a moderately emetogenic combination. And 38% of the oncologists in Europe did not use a combination of an NK1 receptor antagonist, even in highly emetogenic chemotherapy combination. So this is important, because if the oncologist perceives the emetogenic potential to be low, then he or she is unlikely to use additional drugs to control it. We have a host of drugs available. Palonosetron, granisetron, ondansetron are available in India. We have dexamethasone, methylprednisolone. We have netopitant, aprepitant, and metoclopramide, the old age and original antiemetic, which was used till 1980s. So there are very standard guidelines for acute CINV. If you have a high emetogenic group which has either anthracycline cyclo combination or without an anthracycline cyclo combination, the antiemetic cocktail to be used is a 5-HT3 receptor antagonist with dexamethasone, that is a steroid, plus a neurokinin receptor antagonist, that is either aprepitant or netopitant. If you are going to use carboplatin in a slightly higher dose, then yes, you can use this combination again, 5-HT3 antagonist plus dexa plus the NK1 receptor antagonist. If you have a moderately emetogenic chemotherapy or a low emetogenic chemotherapy, you can probably skip the use of NK1 receptor antagonist and use either 5-HT3 with dexamethasone or 5-HT3 with olanzapine, which is another drug which can be used to control nausea or vomiting. If you have a low emetogenic potential chemotherapy, you can use either of these things. You need not use 5-HT3 and dexa. You can use either 5-HT3 antagonist or dexamethasone. But unfortunately, in practice, we often tend to use the same. This is something which we need to pay more attention when we delegate this job of giving chemotherapy to our residents and assistants. Often they start the pre-medication before we even come for rounds, and we often see a patient even with moderate emetogenic or low emetogenic potential taking 5-HT3 receptor plus dexamethasone plus something else. And I'll come to it as to why these things are not good. If you have delayed nausea and vomiting, if you have a highly emetogenic chemotherapy, then NK1 receptor antagonist plus dexamethasone is the preferred combination, plus olanzapine. Also, you can add olanzapine. If you use carboplatin, then you may use only the NK1 receptor antagonist. In the moderately emetogenic combination, you can use only dexamethasone and olanzapine. You need not continue with the NK1 receptor antagonist. Delayed MSS is not so much of a problem in the drugs which are considered to be low emetogenic potential chemotherapies. Now, these drugs have been used since donkey's years. 5-HT3 receptor antagonists, we started our careers using ondansetron, and then came granisetron, and they are they have 3 and 9 hour half-life. Palonosetron is a second generation drug with a half-life of almost 40 hours. So you can give it one per cycle, even for a 3 or 5 day chemotherapy. And these are favored drugs for acute chemo-induced nausea and vomiting. Whereas palonosetron being a delayed with a longer half-life, you can use it even in delayed CINV. But the most important thing is their adverse events. They can cause headache. They can cause bad constipation. Even simple ondansetron oral tablets also can cause significant constipation and elevation of liver aminotransferases levels. A lot of our patients on chemotherapy come to us with deranged LFTs, and we often blame it either on a fatty liver due to chemotherapy or disease or something else. But these drugs can also be one of the causes of raised liver aminotransferase levels, and that has to be kept in mind. QT interval prolongation is also an important thing, which often is not checked, is often not seen, and that is something which can be attributed to 5-HT3 receptor antagonists. Neurokinin receptor antagonists, they involve blocking the binding of substance P both peripherally and centrally to the NK1 receptor. And we have aprepitant, fosaprepitant, and netopitant. These drugs are usually administered with 5-HT3 antagonist and a steroid. But remember, again, these are also known to produce fatigue, headache, anorexia. Paradoxically, they cause diarrhea and increase liver enzymes. This is transaminitis is an important toxicity, and that can lead to delays in chemotherapy administration. Corticosteroids, why and how they exactly work is not very well established. The standard corticosteroid has been dexamethasone. It is commonly administered with other drugs for a better efficacy. And in low risk patients, you can use only dexamethasone and you can do away with other things. But remember, steroids in the long term use are never good. They can cause insomnia, epigastric discomfort, gastritis, weight gain, and especially in people with borderline sugars, it can produce frank hyperglycemia, especially if used for a prolonged period. We have other drugs like olanzapine, which is a antipsychotic. It works by blocking dopaminergic and serotonergic neurotransmission, but it can increase the risk of extrapyramidal symptoms, and especially in combination with an NK receptor antagonist, it can sometimes produce really bad constipation. Benzodiazepine is an anxiolytic medication which we often use in anticipatory nausea and vomiting. It may also be used to treat breakthrough or refractory CINV. The problem with prolonged use of benzodiazepines is sedation. The cannabinoids is a new drug which is coming up for the treatment of CINV. Right now, we don't have an effective drug for the use. There is one company which has come up with a cannabinoid receptor, but it has the use is very, very limited. There is a small trial of nabiximol which has shown promising results in patients with refractory nausea and vomiting, patients who are refractory to first-line therapy, especially for moderately emetogenic chemotherapy. Of course, cannabinoids can cause standard AEs like drowsiness, fatigue, and confusion. There are some other non-pharmacological methods as well, like relaxation. You can use medicinal plants or certain herbs, which even by aromatherapy can help nausea and vomiting. Simple ginger supplements is known to produce less nausea and vomiting, and even change in diet. Sometimes a lot of our chemotherapy patients tell us that the smell of cooking food, the smell of using oils, the frying oils, puts them off food, and they really start feeling nauseous with that. So maybe sticking to simpler diets, which doesn't involve a lot of seasoning, a lot of frying, can be an alternative to the regular food which is offered to them. India has a rich culinary culture, and we have plenty of options available for our patients, and we have to mix and match these food options so that patients continue to maintain their nutrition well. Now, the thought has been to spare dexamethasone. Dexamethasone by itself. Now, we have several other drugs which are so effective. So, can we avoid dexamethasone? Can we do away with dexamethasone altogether? There were two studies, one at ASCO 2021 and one at ASCO 2022. The first study was the All-NEPA study in ASCO 2021. This was a study where they did not use dexamethasone at all. Patients were put on only palonosetron, that is a 5-HT3 antagonist, with netopitant, which is an NK1 receptor antagonist, and olanzapine. So this data, even if dexamethasone was omitted, the chemotherapy related side effects of CINV did not change significantly. Overall, the control was fairly good and fairly comparable to the standard 4-drug protocol of DEXA, 5-HT3, NK1 receptor antagonist, and olanzapine. So you may use it. The study presented last year was even better, that instead of using 4 days of or 3 days of dexamethasone on multiple days, you use netopitant and palonosetron and use a single dose of dexamethasone. And the table clearly shows that the acute emesis, delayed emesis was no different with single use of dexamethasone, and thus you can spare the use of dexamethasone even in highly emetogenic setting of cisplatin-based therapy. So to summarize, chemotherapy-induced nausea and vomiting is a major hurdle in the administration of chemotherapy, and emetogenicity of chemotherapeutic agents is often underestimated. We have effective antiemetics now available. The trick lies in judicious use of these drugs, either alone or in combination, to help control these symptoms. Tailoring of antiemetic therapy based on patient factors probably will yield better results, and there is definitely a scope for research in non-pharmacological methods to control nausea and vomiting. Thank you.